I'm terribly excited to be seated once again with Dr. Ramesh Ardhanari, the Chief of Surgical Gastroenterology at Meenakshi Mission Hospital. If you all remember and watched the earlier video done many years ago where Dr. Ramesh has taken us through his childhood, his college, education and the troubles he has gone through to reach where he has reached. Welcome sir, nice to see you again. And actually I could snatch him from a conference and on his way back home, and I thought I'll get much more than what he told us those days. Now looking back into your career, like if you have to give yourself a mark out of 10, how much will you give and why?
Looking back at my career, maybe I would give myself, say, somewhere between 7.5 and 8 out of 10. Why? Because I think, one, academically I achieved the highest degrees that one could in one's field, MBBS, MS and then MCH. Secondly, I was able to establish a department and make it into a teaching department, and I have taught lots of students, and that has also given me pleasure, and it has given me a sense of belonging. And but then I don't give myself full marks, because I think I have fallen short in the academic field of writing papers, and for the amount of work that we have done at Meenakshi Mission Hospital, if we had had enough secretarial help and other help, we could have produced papers of really good class. And the fact that I started doing laparoscopic surgery so early, so I have done a vast amount of work in laparoscopic surgery which I have not published, which I have not written about. I am also proud of the fact that there are many procedures in laparoscopy which I think, at least in India, I performed for the first time. In the world, I performed for the first time the first hydrated cyst way back in '93, which was published in the newspapers but never in a journal. And then I did the first total proctocolectomy, first D2 laparoscopic distal gastrectomy, the first minimal access thyroidectomy, the first minimal access axillary lymph node dissection in India for the first time. I also did, I have done about 3 years back now, the largest adrenal pheochromocytoma ever removed laparoscopically, a 15 centimeter pheochromocytoma. We have gone through all the literature. There is no mention of a 15 centimeter size, and that too of the right adrenal. Left adrenal would not be difficult, but right adrenal of that size, adherent took so close to the IVC, taking the renal veins and finishing that operation safely was, I think, a landmark achievement. And recently we also did a bilateral adrenectomy where on the left side I removed the pheo away from the cortex, making a cortex sparing adrenalectomy. So in practical work I have done lots, but I think academically I have not written papers, I have not written articles, so I consider that and I gave myself the 2 negative marks, I think, in my career for not having achieved that.
Now, if you have to go through the same rigmarole, how will it be any different in the present era?
I would try to be more academic on that question. That I would have made sure that I could have talked to the administration to give me a little support, secretarial, to maintain the records and maintain the data that I needed to maintain, because I was unable to do it on myself. So by myself. So and then that's why I admire Dr. Ramesh a lot, because he maintained his own data and he always analyzes it and he keeps it on his laptop. He has done so much work to do that. I just probably didn't have that much drive. If I had to go through my life again, probably I would try to get the drive and get that done and get some help and perhaps write more papers.
Now you've done all these adventurous surgery. You just keep on upgrading yourself in the private sector, because anybody in the private or say corporate sector are scared to experiment. They only limit themselves. What is that drove you that you kept on experimenting?
Because what that drove me was that I was not going to have any access to a government setup. So I had to do it in the private setup or not do it at all. And I felt that if I did it, I was very confident of my open surgical skills, because I had a very good training in All India Institute. I had spent 3 years in general surgery as a PG and 3 years as a senior registrar. So I was very confident of my open surgical skills. So I knew I could do laparoscopic experimentation and things, and if there was a problem I could salvage it by open surgery if I landed into a problem. So because of that, I think I was able to do that. And also generally speaking, professionally, I have been quite courageous in my attitudes towards patients, and I explain to them and then I take them up and I have done it. So much of the laparoscopic surgery I have learned myself. I never saw cholecystectomy in the theatre before I did a lap chole. I did it by watching a video and reading a book by Dr. Udvadia, and we did the first lap chole. It took me 2.5 hours, I remember. But what pleased me was that it was a demonstration equipment brought by Stryker, and when we finished the operation, the technician who had come from Bombay with the equipment, he asked me, "Sir, you would have done about 20-25 cases the way you did it." I said, "This is the first case I have seen and I have done." So that pleased me a lot, that he thought I was very experienced, so it showed that I could do it.
See, did you have any godfather during that era? Because there are many surgeons who, when they got into trouble, they had somebody to.
No, I didn't have anybody
for advice.
No, nobody to advise and nobody. But I had a godfather in the sense that the chairman of the institute, Dr. Sethuraman, was very supportive of me, and he never bothered if complications occurred or something. As long as we had managed it and talked to the patient well, kept the lines of communication open. And as long as we did that, and he was aware of our sincerity towards the institution and towards the patient, he was always very supportive.
If I ask you a sensitive question, are you happy with the money you made? Do you think you could have made more money?
Oh, I could have made much more money.
You have any regrets in that regard?
I could have made much more money, but I have no regrets because I am comfortable with what I have. It is not that I don't have money. I would have had maybe 2-3 farmhouses and much more money than what I have today, but then my work may not have been as pleasing to me as it has been. So it's a work money balance. So I was able to do many more cases, and because I was working and I was not greedy for money, so whatever equipment I asked for was bought and given to me, because the hospital knew that I would generate a profit from it. So they gave me the endoscopes, I made a profit for them. They gave me the laparoscopes, I made a profit for them. So whatever instruments they gave, I made profits. So they also encouraged me we were the first hospital over Bombay or Delhi and anywhere to buy the harmonic scalpel in India. And so so those things I may not have had in other hospitals where I would have made more money. But then many of those people I've seen, they used to be jealous and say, "We don't have the equipment that you have. We can't do the procedures that you do," because so they made more money because they did more cholecystectomies and appendicectomies and charged more and got more money. But then they couldn't do what I did because they didn't have the equipment. So it's a balance. So I chose the balance of, but I was not badly paid. So I was having enough, because I had to make sure that I had enough money for my children to be well educated. They would have a house, we would have our own house. So I wanted that, and those I achieved, so that is enough for me.
What is the role of your wife in your career? Because quite often wives will not be happy to live in a smaller city like Madurai. They would.
Yeah, my wife actually would have preferred to. She's Bombay born and brought up, so she would have certainly preferred to be staying in Bombay. But then after the marriage, I didn't have the opportunity to get jobs in those big cities, because many of the corporate hospitals asked for buying shares or asked for money to be deposited before they would give a consultation, which I didn't have. So I couldn't do it. So I moved to a second tier city. and also I didn't want to compete with people like Rangabhashyam and Krishna Rao and all that. So going to second tier city seemed to me to make sense that I'll be the first person with a degree in what I have, and maybe I can establish myself, and in that way I did establish myself, and I have had the pleasure of operating on so many surgeons, doctors in that area, and who have come to me because they trust my judgment and skills.
There are two very interesting things in your career. One is, after joining Meenakshi Mission, you never moved out of it, because there's so many will keep moving from place to place. What is the secret behind that?
The secret, I think, is that the hospital gave me respect. More than anything else, chairman never denied me anything that I asked for. Whatever equipment.
Why? How?
Because he knew that I won't try to make money out of it, and I would bargain with the companies and get them rates for buying this equipment, which they will never get if they had asked for it. Because, and why did the company give the rates? Because they knew I was a very good advertiser for them, that people would come learn and they would see that, and then I would go out and demonstrate that equipment, and they had a lot of advertisements, so they would give me very good rates. Even now they do. So that is one of the reasons why.
But the corporates always feel that one man is grown very big, that he's become a bigger brand than the hospital. I should get an alternative for him.
I don't think I became a bigger brand in the hospital, and they have seen my loyalty through the years. They know that I have been called by many hospitals outside to come and work, which I have refused. So they are aware of it. So they are happy for me to work, and they know that now at this age I am unlikely to move out. So my next would be retirement whenever I do retire, and so there will be no question of my leaving them high and dry. And I have developed a second line, a third line also. So in my department everybody is been doing a lot of their independent surgery. I have also now in the last 5 years given each person's responsibilities of their own, so that one person has taken over liver transplant. He looks after the logistics of liver transplant. The other person goes and does the actual work of the transplant. He assesses, sees the cases, talks to the patients, looks after the post-operative periods. He also does all the liver surgery. We have all referred our liver surgery to him. Similarly, one person we have referred all our bariatric surgery to him, so that that they become experienced at it, that they all get, so they get everybody.
But they all respect you.
They all respect me, I think.
As a HOD.
As an HOD, yes, they do respect me, yes. Because I have given them a very free hand, and I make sure that they have got sufficient money, so they are happy.
Now the second interesting thing is that your assistant stayed with you for so long. You know, because if in the present era, if somebody comes and joins you, and in a year or two understand that they can do as much as you can do, then why should he be, in a bigger position than me?
Yeah, so the question is that it is what you do. You teach them, you give them opportunities, you give them responsibilities, but also you share the money at a level at which they are happy. So with the senior consultant like Mohan, I share my money 50-50, which is not done by any of the other departments in our hospital, where the senior consultant wants to give majority of the money. So that is why they leave them. But in here, because he knows that I have given 50-50, he is happy.
But this formula doesn't work in other specialties.
No, it doesn't work in other specialties. See, it depends on the HOD, no. So the other heads of department, they don't want to share, they don't want to give them responsibility, because they are afraid that their space will be usurped. I have never had that fear. I said, if somebody comes and tries to throw me out, I will go out and I will survive somewhere else. I have knowledge, I have skills, and I have made a name. I can go elsewhere and survive.
That's a very special attribute to be able to share, the space and money, and that's not usual.
Yeah, so that is why.
Now, your assistants also have the same mentality that they'll bring another generation?
I don't know about that. That when they become HODs, they will have to see how they act, how they react. So we don't know that. I hope that they have seen this and that they will use this as a New, at least they all get along with each other. There is no fights in the department.
Why?
No.
How?
Because each person has enough work. See, when are fights occurring? Either there is not enough work, not enough money, so you have made sure that they get their money, they get their work. So the bariatric surgeon, when he does this, I have made sure that since nobody else does the bariatric, he sees the patient, he talks to the patient, he operates the patient, he manages the post-op period. I have told them that whatever money comes from that patient, as an incentive, give it only to him. So he is happy that we don't take anything from him, because he does all the work, he gets all the money. Similarly, the transplant person who is getting, he gets the highest amount of money from the transplant. So we all, so I have given all this away to people so that they will be monetarily satisfied and work-wise satisfied. See, these two things have to be met. So most places people get unhappy because they don't have the money or they don't have the work.
Right.
The chief tends to do all the big cases. I have long ago given up so many cases to everybody and made them all do the cases. Even cases referred to me, some of them are done by them. I stand there, I assist them, I make sure it's going on smoothly. But I know they will do a good job because they are all well trained.
But majority of the patients keep coming looking for Dr. Ramesh Ardhanari.
Yes, yes.
They aren't unhappy that Ramesh Ardhanari is outside the theatre and surgery is going inside.
Whenever the surgery is going on, I am inside the theatre. So any cases which are referred to me, that a patient is being operated, I am inside the theatre. I don't come out.
Isn't that difficult to be inside the theatre not really doing the real thing?
I can sit in the doctor's room and read a book or this thing. So when the operation is over, I go and tell them it's over, it's been done, it's all right. So and my name is on the list, so they know that I've done it. So I sometimes very VIPs, I will do it myself.
Now the medical education or a surgical education wise, the students are dime a dozen now. The numbers have increased tremendously.
Enormously. Yeah, too much I think. Yeah. And see, this is going to be a big problem. Nobody here is realizing. They think that by opening a college in every district, they are doing something great. And private colleges are also opening everywhere. They think that they will, but they are all going to pay the price 10 years from now. There will be no jobs for so many doctors. See, it's impossible for so many doctors to do work. See, they also have competition from BHMS, BAMS, Unani, Ayurveda doctors and everything. So they have competition across all levels. And so what this is going to do is that this is going to create a lot of unethical practices. Unnecessary operations will be done. Yesterday I saw 3 patients who had been referred for surgery and I told them you don't need surgery. So, and I sent them off, and the administration will never question me because we also did 12 operations yesterday in the theatre list. So we do sufficient cases. So when it is not deserved to do a surgery, we send them off. The administration doesn't mind.
Right. Now these students who done MS general surgery, do you think all of them should do super specialty?
I don't think it is possible because I don't think there are that many seats. There is a role for general surgeons, especially at the smaller towns and things. But if they want to stay in major cities, I think the problem is that general surgeons, I don't know how much they can survive. Unless they have their own.
Is the general surgery department in your hospital?
No, we don't have a general surgery department.
Why?
Because we have all specialties. So we have urology, we have gastroenterology, we have oncology, we have plastic surgery, we have pediatric surgery, we have neurosurgery, cardiothoracic surgery. So there is no work for a general surgeon. Hydroceles are done by the urologists. Hernias in the adults are done by us. Pediatric surgery does the pediatric hernias which come to them. Oncologists do, we don't do head and neck surgery, nobody. So the oncologists do all the head and neck surgery. The ENT people also do head and neck surgery. So between them they share the head and neck surgery. The oncologists do occasional GI surgery. We do a large amount of GI surgery because we have been doing it for many years. So we have got nothing for a general surgeon to do.
No, but if you have a 5-year DNB neurosurgery, they require 1 year of general surgery.
General surgery, they come to us and to oncology. So they spend 6
That is acceptable to the national board. That's general surgery.
We have a general surgery department headed by one person, one of the super specialties who doesn't have an MCH course. He heads the thing, and the people who don't have the super specialty course, they are all faculty for that general surgery course, and they spend time with them and with us. So they learn from us GI and other things, and they learn from the oncology, head and neck, the neurosurgeons, the head and neck and other parts. So they all learn this in these two departments. So like that we have managed.
Now, if I am a freshly passed MS general surgery, then I realize that I should be in one of the peripheral centers. How much more training should I undergo and where?
No, I think what
as a general surgeon.
I think the problem is that we think of 3 years of MS that we are qualified surgeons. This is a mistake. The ideal training for a surgeon like United States should be 6 years. Okay, so I think that this is where the senior residency is a very important position to do. So you do 3 years of general surgery and then you do 3 years of senior residency.
Where will you do?
In any hospital which has got a busy thing. All the hospitals in Delhi, they have full lists and theatres now, and they've got many senior resident posts. They've got so many. See, we have a 1.3 billion population, so patients there is no shortage. So we have enough hospitals and places for people to go and learn.
Now, if I just pass MS general surgery, say from Keelpark Medical College, where will I apply for senior residency?
You have to apply wherever the post is up, this thing. So some people have gone to All India Institute, some have gone to JIPMER, some have gone to KGMC, some have gone to MAMC. Others have gone to Safdarjung Hospital, Vardhaman Medical College. So from our own DNB PGs, and they have gone to other places to work, and they learn a lot of surgery at that time, spending 2-3 years as senior resident, and then they decide to either practice. There are 2 or 3 of my DNB general surgery students who are now in practice and doing very well. One is in Erode and another is somewhere in Kerala. They are doing very well in practice because they have spent time with us. They are very confident laparoscopically and in open surgery, and they are doing all these procedures, and they are called by many other surgeons to help them during surgery because they know they are well trained. And then they
are trained under you.
They have trained under us
in general surgery.
In general surgery, because what happens is they spend about 1.5 years with us, then 6 months with oncology,
right,
and then they spend another 1 year rotating with urology, neurosurgery, CTVS and other things.
Yeah, but Ramesh, you should understand that the number of MS pass outs is not equal to the number of senior residents available. Where will they go? Now suppose I can't go to Delhi, I can't go
to then I think you should look for places in mission hospitals. There are many mission hospitals across the country, like in Nagarkoil there is one, Karaikudi there is one. So these mission hospitals often have a very busy general practice, surgical workload. So plus you also have to assist the gynecologists in hysterectomy, cesareans and all that. So you get quite a bit of cutting, so your hand becomes fluent. Spend 2 years, even Dharapuram Mission Hospital, where John Tanakumar worked, he said that it was so busy that he got so much surgery to do that he, after his MS, he went there and he learnt a lot of surgery there. So he did on him, and you are independent, so you are responsible. So that makes the difference. So I think they have to look for all these places. The problem is that they think that MS, they are fully trained. They are not. They have to spend those 2-3 years getting their hands clean. And I think that the wisest decision I made was to do the senior residency of 3 years. So though I didn't do any surgery in my MCH 2 years, but I didn't have any difficulty when I came out to practice because I had done so much of surgery, and I knew the principles of surgery, so I could read and do the operation.
Now you would have noticed that a newer tribe of hernia and AWR surgeons has come up. What is your take on that? Because many times youngsters who attended 1 or 2 courses, they think they are good in that area.
Yeah, but I think there's a lot of work to be done. Incisional hernia rates are very high. I was recently reading a paper where they followed these patients for 10 years and the incisional hernia rate was almost 60%. So that means that there's a lot of room for people who specialize in hernias and incisional hernias, and if they do good work in that field, they will soon get a lot of places. Like my friend Jai Singh Shinde in Maharashtra, who does only hernia work, but he does some advanced work, so he gets a lot of patients from other places.
Your hospital has any hernia specialists?
No, we only in our hospital, we do the hernias, so we are doing it. Dr. Bose has gone and done some training, so he is now getting into some of these advanced procedures. Otherwise, all of us do the laparoscopic and open hernia repairs. We do I have been doing all this, so all these people now talk of tissue separation techniques. I have been doing it for 40 years. From the time I came from All India Institute, all my incisional hernias I always do by tissue separation. I make a rectus incision and I reconstitute the linea alba and then put a mesh across the defect.
What is your take on these FALS and FAIGS?
I think these degrees are not going to make you able to do anything. These are only to open your eyes to what is possible. So by doing a 3-day course, you are not going to become a laparoscopic surgeon, but you will know the amount of laparoscopic surgery that is available, that is possible, and then you can decide to further go into one of these fields. And I think that what is going to happen in the next few years is that we are going to see more subspecialization. So now we say MCH GI surgery. I think GI surgery will now split into an upper GI with esophagus and stomach and going into one, second will be colorectal, third will be hepatobiliary, and fourth will be liver transplant. So those who do transplant will do only transplant, because that itself is quite a busy work for them. So they will be doing that. So I think this is going to split, and I see that the oncology is also going to split into gynec oncology, into GI oncology, and into head and neck oncology. So 3 separate specialties will come up in the next few years, and this question of oncologists trying to do everything from head to toe will disappear. They will be specializing into one of these areas and they will keep doing, and they will do better job. See, what one should realize is that when you limit your surgeries to special areas only, you do a better operation. So in our institute, we used to do about 20 liver resections a year, 15 to 20, but shared between 4 surgeons. Each will do 5 or 4. So now I have given it all to one person. He is doing now 20 a year. He has done it for the last 3 years. He has become much better at it. He has now done laparoscopic liver resection. He has done things like that. So he is improved into that. Same thing with bariatric. Everybody doing 1 case, 2 cases every 3 months, 4 months. One person does it, he does 2 cases, 3 cases every month, and now he is increasing the numbers. He is also doing endoscopic bariatric. So his interest is that. Let him see, somebody is interested, you should push that interest up and give them the responsibility. So what happens in many places is somebody is interested in something, the others will try to pull them down. In my unit I have encouraged them, so that way they have become happy.
I ran a Facebook group called Learning General Surgery. It's got over 43,000 members, and quite often the discussion or the questionnaire will be, which is the most lucrative subspecialty? I have finished MCH gastro. Now which one will, actually for the matter, even for MCH specialty, people want to know how will I make a certain amount of money quickly.
I think if you look at lucrative wise, I think if you go and spend a year and a half or 2 doing fellowship in liver transplant, then go into a liver transplant, that is going to be at the moment the most lucrative, because the charges for the transplant are high, patients are willing to pay, and everybody gets a good amount of money out of it. So everybody makes money out of it. So I think that is today the maximum earning. The next level will be those who do laparoscopy and do advanced laparoscopic surgery. So they get more patients because they do advanced laparoscopy, and so they will make money. So these are 2 are going to be the most money making specialties. Second is going to be oncology, and or even first is going to be oncology, because oncology is going to get a big boost because people are opening cancer centers, government is pushing for cancer centers. So oncology will start going to cancer centers where cancer surgeons would be the ones that will be recruited, and so that will take away work from many other specialties like GI surgery, pediatric surgery and other things. As a matter of fact, pediatric surgery is almost becoming a sort of an extinct specialty now, because
no takers.
No takers. There are more than 60 seats in Tamil Nadu itself which are lying vacant for MCH in pediatric surgery. Similarly, in plastic surgery also. So, plastic surgery can be very rewarding if you are a good surgeon and you can do top class cosmetic surgery. Actually, probably in the United States, the number one earning people are the cosmetic surgeons, the ones who do the face lifts, the breast lifts, the breast augmentations, shaping the buttocks and the thighs. So, they get maximum money because they are doing, but then the risks are also high. Things go wrong, then you can be in deep trouble.
Now, I have just passed MCH, I want to take up transplant surgery. But transplants are not done every day.
Yeah.
What will I do the rest of the days?
See, the thing is that you have to first go and work. See, you will work in a transplant center. You will go and learn surgery. These transplant centers like Medanta, like Max, like Rela Center, like Vidge Center, they do 250 cases a year. So, they are doing almost one a day. So, you have busy work. So, you will 1.5 to 2 years see 400, 500 patients, you will be well trained, you are beautifully trained. Now, you have to go and establish a transplant center or join a hospital which has a GI center, and they will be looking for somebody to start living donor transplant who is well trained, then they will be the people to go and start that. So, I think more centers will start doing transplants, and then they will be doing, if they do a good work, they will be able to survive. Even if they do 3-4 in the beginning per month, and the hospital will probably give them a basic salary, and then they will earn some money from the thing. But they should negotiate with them that for 2 years I need you to give me a salary till I build up my practice, and then we will see at the end of 2 years. So, I think, so in our hospital we always give them a salary, starting salary which is quite high, so that they can be happy. To their family will be well settled, they can have a house, a decent house to stay in, they can have decent quality of life. So, I think that has to be done. You can't just tell him that you earn, and from what you earn you do cases, because then he may not get cases if he is the junior most in the department. So, I think that in many hospitals they do that, but in some hospitals they don't. There then people, only the old ones stick, the new ones don't join there.
No, but there was a time when people, soon after they finish their initial degree, they used to go abroad to specialize in surgery. I think that trend is...
I don't think that you need to go abroad today to do specialist training, unless it's extremely advanced surgery. For example, fetal surgery is not a big thing in India yet. One of my friends who was in All India Institute, who I think you also might know, Vijay Mohan Reddy, he is he's probably the world's #1 fetal cardiac surgeon. He does a lot of fetal cardiac surgery. So, he is so if somebody wants to specialize like that, they will have to go there to learn and then come back, and then to practice and build it up is not going to be easy, because you need to get that many patients, that many cases. But more and more fetal surgery is coming up. Recently I was reading about how for diaphragmatic hernia, they are putting intrauterine endotracheal tubes into the lungs to inflate the lungs, and that is one of the new things that is taking off, and the results are much better than others. So, these things are the cutting edge technology. Probably you will have to go abroad if you want, but for the general specialization, I think India is more than enough.
Now, people also keep asking questions like, should I take up MCH in KM or DNB in AIG or something in Lucknow? How do you decide which hospital to take?
I think this is a decision that you have to make depending on, nowadays these WhatsApp groups are there. So, all the boys are putting whether they are getting chances, they are not getting chances. So, some hospitals have a good reputation, some hospitals don't have a good reputation. But you have to choose. One is that you may not have a choice. Only the higher rankers will have a choice.
Right.
And then you have to also look and see what you want to do. Do you want to stay in a place like JIPMER and be an academic person, or All India Institute and be academic? Then I think you should try to get into those academic centers and do it, if possible, and then get into a faculty position there. If not, if you want to do practice, then I think you have to look for a center which also teaches you what you will need in practice. See, whether you like it or not, if you are a GI surgeon, in practice you will have to do laparoscopic hernia repairs.
Right.
That is one of the biggest earning areas.
Right.
So you have to do that. Nowadays, I always tell this, in 2000 I started doing laparoscopic hernia somewhere in 97. In 97 to say 2000, 2001, we never used to push for laparoscopic surgery. So 10 to 15% of our patients will have laparoscopy, 90% or 85% will have open surgery. It completely changed now. 90% patients come and ask for laparoscopic surgery. So you have to be, somebody has to provide. If I didn't provide, there will be some general surgeon who will come and say, I will do laparoscopic surgery. So to keep myself into the position, I am a laparoscopic surgeon. I started doing lap hernia, and I do lap hernia even now. All my colleagues do lap hernia, so that we are competitive. So we get cases. See, every case brings money to the hospital. So the more cases you do, the more respect your department gets from the hospital.
See, I am a fellow from Hyderabad, Andhra Pradesh. When during my career, how will I decide where will I settle down for good? Should I settle down in Andhra Pradesh and Hyderabad, or you have any criteria?
No, I don't have any criteria for that. I think you have to look at which is the hospital. But I think unless you are comfortable with the local language, to be a doctor and at a higher specialty level will be difficult, because you will always keep requiring an interpreter to talk. So born and brought up in Calcutta, you speak Bengali, you can stay in that place. So many South Indians have done like that. Ramanna, for example, he stays in Calcutta. He is from South, but he has been there. So like that you stay, and then you continue to do your practice there. You speak fluent Bengali, you are Bengali like everybody else, there is no difference. So everybody respects you. So when I decided to practice, I thought, since I am a Tamilian, I will stay in Tamil Nadu. But I could have stayed anywhere because I know Hindi fluently.
Right.
I could have stayed, but my financial circumstances were such that I needed to practice to make some money. I didn't have any backing, father didn't leave any legacy and of houses and land, and also I had to do everything for myself to make sure that my children don't suffer and others don't suffer.
Now, your students love you so much. You know, they've made movies about you, and each and every student have such a respect for you. What is the reason?
I think I get along with them, I joke with them, I teach them. I teach them regularly. I scold them also.
But if you teach them, don't you think they'll become your competitors? You eat part of your cake.
I don't bother about that. That I don't bother. I think we all have enough cases, so I don't bother about that. So I teach them everything. And I see, this is what I keep telling. If you don't want to teach, then why should you start an DNB course or a thing? Then don't start the course. If you think they'll become competitors, don't use them as slave labor, which is what many centers do, which I don't like. If I have started a teaching center, I would like to teach them so that they go out, and it's a selfish reason that I will get a good name as a teacher.
So you've been a mentor to them.
Yes.
They get back to you at every stage of the career, their life, and they share their stories with you.
Some of them do. And many of them do come and visit us when they are in the area. When they are in a conference, they'll come and see me and then tell me how they are doing. Some who have not been happy with me, or whom I have scolded or given them a piece of my mind more than others, may not respect me as much. But the others who will come and say, sir, whatever you taught I apply, and that has been the story of my success. I am highly regarded in my center. Everybody asks me. Even to the extent that our nurses in the theatre who go out, one nurse from our theatre went to Bangalore, and I met the surgeon and he said, your nurse has joined our hospital, and in laparoscopy when you are in trouble, she will say, Dr. Ramesh will do this, sir. And then we do that, and we have learnt from her so many small tricks and tips. So even the nurses can be your marketers, or sort of, spread your name.
So on that note, thank you so much, and there is so much I am sure youngsters will learn from watching this video. Sorry to keep you.
No, it's my pleasure. It's my pleasure.
And I'll meet you again some other time with some other topic. Thank you so much.
Thank you.